Welcome. My name is Nikolaus Mezger, and I'm happy to present our collaborative research between Halle University and the African Cancer Registry Network on NCCN Guideline-Concordant cancer care in Sub-Saharan Africa. We conducted a population-based multi-country study on 5 cancers. Cancer is becoming an increasing public health issue in Sub-Saharan Africa. In comparison with other regions, cancer in Africa is associated with particularly poor survival. This is why a number of national and global strategies have been rolled out to improve cancer infrastructure. These initiatives rely on identifying priority targets through regional cancer surveillance by the African Cancer Registry Network. Epidemiological indicators such as incidence or mortality need to be complemented by clinical care indicators to further improve national strategies. Up to now, only aggregated data on clinical infrastructure is available. Data on clinical management of individual patients has been published on hospital series only, limiting generalizability to the population. Our study set out to fill this research gap, assessing clinical cancer care on individual patient level in Sub-Saharan Africa. We asked the following research question. What's the quality of clinical care in patients with potentially curable cancer based on the NCCN harmonized guidelines for Sub-Saharan Africa? Looking at potentially curable cancer allows for better evaluation of guideline concordance. For this purpose, we used resource-stratified guidelines developed by leading African oncologists and the National Comprehensive Cancer Network that were specifically tailored for this setting. The AFCIN is home to over 30 population-based cancer registries, of which 11 centers in 10 countries provided data on 3,246 patients randomly sampled. These registry data on 5 cancer types, breast cancer, cervical, prostate and colorectal cancer, and non-Hodgkin lymphoma, were complemented with clinical data by assessing hospital records from all oncological facilities in the registry area. To select patients with potentially curable cancer, we excluded patients for which we could not find medical records in the oncological facilities, patients with unstaged cancer, a known palliative setting, cancer without regional guidelines for Africa, and with short follow-up below 30 days to ensure capturing treatment or lack of treatment. This resulted in 906 patients included in the evaluation with potentially curable cancer and a follow-up above 30 days. For these, a 4-tier therapy evaluation scheme was developed. In each of the 5 cancer types, we distinguished between green, guideline-concordant therapy, yellow, minor deviation, orange, major deviation, and red, no cancer-directed therapy. For breast and prostate cancer, we were unable to distinguish between green, guideline-concordant treatment, and yellow, minor deviation, due to lack of diagnostics on hormone receptor status and Gleason score. Applying this evaluation scheme resulted in some 40% of all cancer patients with either guideline-concordant treatment, green, or minor deviation, yellow. Around 25% were treated with major deviation from guidelines, orange, and 35% with no cancer treatment or without curable potential, red. Stratified by cancer type, around 50% of non-Hodgkin lymphoma and breast cancer patients were treated in concordance with guidelines, green or yellow. But only 1/3 of colorectal cancer patients and even less patients with cervical cancer. When looking at individual cancer registry sites, we found a considerable disparity of patients accessing guideline-concordant treatment within countries. Some patients in each country were treated very well in green, others not at all in red. And disparities were also found when comparing registries between each other. One pattern could be observed in registries with functioning radiotherapy facilities marked with a blue star on this slide. In most of these registries, guideline-concordant treatment was more common than in the other registry areas without radiotherapy facilities. When zooming out from the potentially curable sub-cohort to the population-based cohort, we can see that a lot of patients were excluded from the sub-analysis on the quality of treatment. In fact, when looking at the bottom bar, which summarizes all 11 registries, we can see that only a little more than 10% of patients were treated in concordance with guidelines or minor deviation, green and yellow. Zooming in again to the subcohort with potentially curable cancer, which patients are more likely to receive adequate treatment for their cancer disease? This forest plot shows risk ratios for several covariates and their associations with grouped worst treatment, major deviation or no treatment to the left of the null, and grouped better treatment to the right of the null. When comparing treatment among cancer types with the reference, breast cancer, we saw that cervical cancer and colorectal cancer had lower probability of adequate treatment. This points in part at the more complex and expensive surgical requirements in cervical and colorectal cancer. Comparing early-stage cancers and patients with good clinical status, we see that the probability of adequate treatment is lower in late-stage patients and those with poor health. It is likely that clinicians allocated more treatment resources to patients with a better prognosis. Finally, living in a country with medium HDI increased the likelihood of guideline-concordant treatment almost twofold, which shows that a better economic situation corresponds to a better functioning health system. Why do these results on quality of treatment matter? Does better treatment improve survival? I want to take a moment and look at another analysis on cervical cancer in our cohort. Here you can see the results of multivariate Cox regression for the association between treatment quality and the risk of death hazard ratio. Compared to guideline-concordant treatment as reference, the risk of death increased ninefold in patients without treatment. Further, we can see a dose-response shape of the association from best survival in green to worst survival in orange and red. In the other four cancers, we found similar association between higher quality treatment and improved survival. In summary, this study on population-based quality of treatment can be a baseline for policymakers and can help set priorities. These priorities should attempt and address several issues at once. For example, improved pathological services could increase staging in breast and prostate cancer. Radiotherapy devices will support treatment in breast, cervical, rectal, and prostate cancer. And improved surgery will benefit all cancers. Even for lymphoma, a surgical biopsy is needed in diagnostics. Our study does not answer the question why treatment was given or not. Was it lack of finances or a clinical decision? Finally, I would like to emphasize that further population-based studies are needed to monitor advances in clinical care as countries and health systems in Sub-Saharan Africa develop. I want to thank all co-authors and data collectors and thank you for your attention. Have a great day.